Good morning. So I was very honored to present to be the first presenter of the day. Look, I was a JMO of the year, so I was in your boat back in 2005. But back then, Fairfield and Bankstown Hospital were not able to take interns independently. I was the Liverpool, so-called Liverpool Hospital intern, but it was actually what we call Southwest Sydney Area Health Services. So the first term I have done was emergency. So that if you commence with an emergency term, it's good that you learn a lot of the skill in a very short while within that 12 weeks attachment. The bad thing is then you don't know anything about the logistic within the ward. So my second term, I then being seconded to Fairfield to the general medicine term. So it's kind of hard because the third term when I come back to Liverpool, I basically don't know how the ward runs in Liverpool Hospital. I have no connection with any administrators or any admin persons and the nursing staff as well. But nevertheless, you eventually will find your way. And it was a very interesting experience when you go to different hospitals. What I'll be discussing with you, and then later on, I actually joined ONG training, but then I stopped doing the ONG training after 3 years. And move on to the palliative care training as well as GP training. So I'll be speaking to you, with all of you, very briefly about how you communicate with the GP, because when a patient comes into the hospital, a lot of the time it's because they refer by the GP to go into the hospital, go into the emergency, and that's the most common route that they come into the hospital. And then when you're about to discharge the patient will be cared in the community by the GP again. So even though the GP doesn't directly liaise with you while you're doing a term, but ended up at some point, you will be discharging the patient back to the family doctors. So the first thing is you have to understand how the GP works. Anyone with an MBBS, or now you guys all call MD, but anyone with an MBBS before 1996, March 1996, as long as you have done a short family medicine training program, you can become a GP. You don't necessarily have to sit the exam before the 30th of March 1996 to be the fellow of the Royal Australian College of GP to be a GP. So back then, that's what we call vocationally registered, VRGP, all right? So government actually put them into two categories. If you have done your family medicine training, after 30th of March 1996, you will be recognized as a VRGP. So you get a higher Medicare rebates. And those one without the family medicine training program before, or they haven't been a GP for 2 to 3 years in a row before the 1996 cutoff date, they will then become the non-VRGP. And until they finish the exam with the fellow of the College of GP, they cannot get a higher Medicare rebate rates. So, but that was the cutoff date, 30th of March 1996. If you're not an FRAC GP and you haven't done a family medicine training, you can no longer become a GP, which is, and Australia is actually the first country in the world that demand all the GP to have a specialist registration in the specialist register with the medical board. So essentially all the GP at this point who are still practicing, they have to be a specialist in general practice with the Medical Board of Australia. So the national registration of the medical practitioner only came through on the 1st of July 2010, not 2020, I apologize, that's a typo there, 2010. So it's about 12 years now. So by the time I was practicing, or a lot of the other doctors was practicing, when we first graduated, if we need to go from state to state, we have to apply a state registration. So I was recognized in New South Wales. If I need to cross the border to Victoria to practice, I have to ask for a mutual recognition of my qualifications in order to cross the border to practice. But after 2010, you no longer need to do it. So it's a national registration, and general practice is recognized as a specialty. So part of the reason why general practice also needs to go and become a specialist in general practice is, number one, is a specialty by itself. And number two is also allowing the community GP can be the staff specialist or take up the staff specialist or VMO position in certain hospital. However, this specialist registration is not compulsory until 1st of October last year. All right, so until 1st of October last year, all practicing GP must be registered as a specialist GP, or otherwise they will lose their Medicare rebate status. So that means the patient will not get the Medicare rebates. The part of the reason why some GP never gone into the specialist register is because they're not taking up any hospital job. They don't want to pay an extra $495 to APRA or to medical boards to get a specialist registration because they feel there's no need to do what they're doing in the community. But last October, basically everyone has to do it. Otherwise, you lost your rebate status. Then essentially any single practicing GP in the community now are specialists in general practice. So you will be dealing with a whole bunch of doctors, and the good thing about the GP now today is majority of the GP that you come across with are the fellow of the college. They're not someone who never probably sit an exam or never have done a college exam or specialist training program, so they don't really know what's going on. So that's a good thing. But you still come across some older generation GP who have never been to the college as the fellow. So it sometimes, they have a lot of abundance of experience in terms of the general in the clinical practice. But in terms of examination support or understanding what you're going through, it could be a bit difficult because it's been so long ago that they have done their training in the hospital. This is a commercial that it was being broadcast many years ago across Australia. But I just want to illustrate the picture here. So when you speak to a GP, you have to understand that GP probably has been through a few generations of the same family or a few decades, or have been looking after this family for a few decades altogether. So they actually know the family extremely well, far better than you or even your registrar or your consultant. A lot of the specialists consider that they know their patient very well, but however, in actual fact, is the GP actually know the family even better than a lot of the specialists because of the fact that certain things, particularly the family dynamics in between the family member, what actually has been going on, the GP will be aware because probably GP look after the whole family. And a lot of the patient, they selectively would tell the specialist colleagues or our what we call a secondary care specialist colleague, certain thing about their family. So you have to, if you want to get a broader picture about what's going on, the prescribing patterns, medication intake pattern, or any issue with the family, give the GP a call. And quite often we receive phone call from the hospital resident or intern or registrar, just to get a sense of understanding what's going on and the patient's drug-seeking behavior or the use of medication behavior or the dynamic in the family. So what do you think a GP will see in a full day of consultations? So in a good day, these are the things that we will usually see, ranging from early to now COVID, because we need to support all the COVID patients in the community. Eczema, urticaria, conjunctivitis, boil, that's all simple, easy stuff. We reset the skin lesions. Not every single dermatology condition needs to be referred to dermatologists. A lot of the GP actually surgically remove the skin cancer, skin lesions, women's health checks, and as once again, not every single pap smear or what now we call cervical sampling that needs to be done by a gynecologist. Fracture of the bone, how we put on the plaster, and managing a lot of the psychiatric disorders, family argument, bipolar disorders, drug and alcohol addictions, how do we support them? Simple thing like gastro, asthma, skin rashes, blood pressure, chronic diseases, metabolic syndrome, STD. All sort of forms that you can never imagine how many forms in this community that we need to fill in, from new cell wells, service new cell wells to RCA to electricity that they want to get a rebate because they have got a obstructive sleep apnea, early release of the super because the surgeon wants to do certain operation and the patient can't pay for it. All this that's considered in a good day that the GP is doing, because a lot of this is actually bread and butter for us. We actually do it all the time. In a bad day, this is what we will come across with. Anyone can tell me now, you're intern, you should be able to recognize it, and you pass your final year exam. Anyone know what this diagnosis is? If you can, just type it in the chat box, but I can't see the answer. Lucy, will you be able to see the answer if anyone has typed in?
Yeah, I'll have a look, but no one's typed anything yet. Come on, guys.
All right, so this is in a bad day, and if you don't even recognize it by this time, by this point of your training or your career, then that's a problem.
We've got a few people saying STEMI, is that right?
Yeah, exactly. That's a very, very obvious STEMI, all right? So if you look at this in emergency and you tell the nurse, yeah, it looks fine, then you're in deep trouble. All right. So, but that's what we will be able to see in general practice. Patient coming with chest pain. We are the one who actually receive the patient. We look at the patients. And then if this happened in a metropolitan area, we stabilize the patient in the clinic and then we call for 000. But in a rural area, that become an issue because a lot of the rural hospitals emergency is actually manned by our GP colleagues as well, who are also the VMO of the hospital. So usually we then have to contact the colleagues who are actually looking after the hospital today, that I'm sending a patient over to you now in emergency with a STEMI. And that's a protocol the receiving and the emergency is going to manage, and then call the general physician in the rural hospital to co-manage the patient together. And what about this? This is in a bad day, and we see in the general practice quite often as well. What about this? Anyone? It's definitely not an MI. Anyone? Getting harder. Our obstetrician professor is looking into it as well.
Looks like a sinusoidal trace.
All right. So any of our intern colleagues, you think bradycardia? Definitely bradycardia. That's correct. That's good sign. All right. So it's very slow. So very slow. And then what you do, obviously, you look at a P wave, and a PR interval. So this PR interval, that PR interval, and that PR interval getting longer and longer, and then pop, disappear. All right. So what's that? Complete heart block. All right. In the old days, you call it 3rd-degree heart block, but in this situation, complete heart block is a clinical emergency. And once again, you can't just rely on it. You can't just tell the patient, say, look, don't worry about it. You just go and see a cardiologist at next whatever available time. You can't, and you have to call the emergency department, speak to the admitting officer in the hospital, and tell them that, and then we need to organize an urgent cardiology review. All right, things like this. This happen in general practice. And what about this X-ray here? Yeah, Professor Chua.
Oh, I was doing the journal club. Looks like somebody with a heart.
Oh yeah, great, man. And pneumothorax, that's right, the pneumothorax, because this right lung is obviously more translucent as compared to the left. And you need to look at the esophagus, whether there's any deviation or not. Sorry, the airways, make sure there's no deviation at all. So look, this is a bad day. That's if we see this sort of situation, we need to manage it. Or come across a breast cancer like this, how do you break bad news to the patient and then organize a biopsy and speak to the general surgeon or the endocrine surgeon immediately for an urgent appointment. So in a bad day, a GP will need to manage, and this is a new thing for us now, COVID with complications, cardiovascular emergency, fractures, domestic violence. Patient will come in, cry in front of you in your room and telling you that that's got domestic DV situation at home. You need to contact the police. You need to contact the domestic violence hotlines, speak to the counselors, make sure the patient have a safe place to go from after leaving your practice. Suicidal ideations, you just have to stop your consult. I stop everyone else from after this consultation. You just have to sit with the patient and ensure that they're fine, and speak to the psychiatry team or the mental health team, community mental health team. Drug addicts, neurocompressions, chemotherapy, radiotherapy side effects. So a lot of things that will be going on. So don't ever consider that. Sometimes, during my hospital training, I never know this is what a GP needs to deal with. So we are very entitled. We felt that whenever we give the GP a call, the GP is going to answer our call straight away. And how would that GP just refuse to speak to me over the phone straight away? You just never know whether your colleague is having a good day or bad day. It's the same as your hospital colleagues. Sometimes the registrar, you give them a call, they say, I need to ring you back. That's probably they're having a really bad case they have to manage. So in terms of the GP training, it's actually a 4 years training program, 3 to 4 years. So you do your hospital term as the first year, and then you do your community term for the next 2 years. And if you're in a rural area, you can also go for what we call an advanced rural skill training, or or advanced specialized training to get different qualifications, whether it's FRACGP or FACRM or FARGP. All right, so that's depending on what you want to do. Some patients, some GP, they want to be a GP obstetrician in the rural area, so they will first of all get the FRACGP, and then they will do an advanced diploma in the obstetric and gynecology, or they will get onto FARGP to get advanced rural skill, and that will qualify them to be the VMO in the hospital to receive and to perform cesarean section and some simple straightforward, when we say simple, straightforward is to an obstetrician point of view, but still, a major, significant operations to operate on the table as an independent operator. So how do you communicate with the GP? Number one, prepare before you arrange. You need to know why you're arranging the GP. Don't just agree with your registrar or your consultant when you don't even know why you arrange the GP for. What questions do you have in your mind, and then what do you want to find out from the GP? And be open and tell the GP who you are. I find that nowadays a lot of the doctors, a lot of the JMO, when they ring the hospital, when they ring the GP, they don't tell them who they are. They just say, I'm Dr. Smith, or I'm Dr. So-and-so, I'm part of the rheumatology team. And often what you will get is the GP will then ask you, because we've all been to hospital before, all right? We will then ask you, are you the consultant registrar or the intern resident? All right, so just be very frank and say, look, I'm the resident of the team, I'm the intern of the team. My consultant would like me to find out from you X, Y, Z. Like, you don't have to hide the fact that you are a JMO. And then so often when you say you are a JMO, you will be treated more nicely, rather than you pretend to be someone at a more senior ranking medical officer, but when a GP question you certain things and you can't answer. Face the reality. Sometimes when you ring, the receptionist or the secretary might say, "Oh, can we jot down your name and address? Your name and your phone number. I'll call the doctors will call you back." But you can always ask them, what time do you think the doctors can call me back, or do you think the doctors can call me back before this time? You need to give a time frame. If there's something urgent, you can say, "Look, I'm calling from emergency, and it's an urgent phone call. Can I speak to the GP, please?" And often you will get through straight away. Be prepared that the GP might need to ring you back and tell the GP about what happened to the patient and what information you need from that person, and what do you want the GP to help you. A bit more specific, regardless whether it's a behavioral questions, it's a prescribing patterns question, or a specific information. For example, have you recently done an MMSC on this patient? And I wonder what date and what was the score? Do you know the patient have a power of attorney? And things like that. Just be very specific. So certain things you have to avoid. Avoid treating the GP like the medical clerk in the community. That's what most of the GP hates. And I know I never have done it, but I know some of my colleagues have actually lodged a complaint to the consultant directly and say, your intern or your resident actually demand me to do this, and I think this is ridiculous. This is what your JMO should have done, or your registrar should have done. And when a complaint goes directly to the consultant, it may not be a good thing for you. And treat each other with respect. You never know whether this colleague will refer patient to you one day in the future if you choose not to become a GP. All right, and this often happened. I tell you what, this often happened. All right. Some of the hospital registrar initially treat their residents very badly, and one day they realize their resident become a GP and they become a non-GP specialist. They turn around and change their attitude and be very nice to their GP colleagues who used to be their JMO, and this JMO is never going to refer to patient to this former registrar. Just treat each other with respect. That's the fundamental request. And if you need the GP to chase up certain results, be specific and provide a detail how to chase it up. When I was an intern in the hospital, I was always being told, just write down GP to chase urine culture, just write down GP to chase X-ray. Look, in a community, we don't like it, because the issue is, it's easy for you to say it, but we don't know how long will that take, and often it's a very time-consuming process for the GP to just hold, ringing into the hospital, putting on hold on the line, particularly now during the COVID period, and asking for the result to be faxed over to us. And so just be very specific. And if you know the number of the radiology department or the pathology department, it will be the best if you can even include that number into the discharge summary, so that we don't need to go through the switchboard, waste so much time there. eventually you have to understand, we are not the one who ordered the test. It's actually your medical legal responsibility to follow up the test that you have requested, not the GP's. You know, by writing it on the discharge summary to say GP to chase XYZ doesn't transfer your medical legal responsibility. You and your team are still the one who medically responsible for it. And don't badmouth the GP, because I can almost guarantee you that the patient will go back and tell the GPs about it, particularly in a rural town. All right. If you are practicing in a setting in a rural hospital, don't badmouth it, because a lot of the patients, they actually trust their GPs a lot. And number one, you know, we shouldn't do that. It's not ethical. And number two, bear in mind, you may have breached the Medical Board of Australia's code of conduct by badmouthing your colleagues. And some colleagues might even ring your consultant or even medical admin to complain about you. And this has happened before. So just be careful with it. So a few pitfalls that I will mention before I finish the talk. The discharge summary, just be succinct and make the GP aware of what's going on, and best to have a discharge plan in detail. If you need the patient to follow with any particular non-GP specialist, for example, your team consultant, please provide the details clearly, and also ask them, just mention that please provide a referral to this particular doctors. And if this is something optional, so it's not necessary, you know, it's not a definite thing, then you can just leave it for the GP to decide who they would like to refer. So for example, like say, instead of saying GP to organize a gastro review for gastroscopy, you can say it's better worded to be like GP to consider whether gastro review is warranted, and to make a referral accordingly. You know, that sort of things will, you know, you give it autonomy back to the GP to consider the situation and also who they would like to refer. You and your reg or your consultant doesn't necessarily know something, you know, what your consultant doesn't know doesn't necessarily mean the GP doesn't know as well, because a lot of the GPs actually come from different specialty training. Like most recently, I had a patient that have seen an oncologist, and the oncologist doesn't know what's going on with one of the skin sores. And so he already called for dermatology clinic review. When the patient actually came to see me, because it's going to be another 3 months away, the patient came to see me and I look at it, it's actually just very simple skin infections. So I prescribe antibiotics and antibiotics ointment. The skin lesion actually is gone in a week. So things like this often happen. You know, you raise the case to a tertiary teaching hospital level, but in fact it doesn't need to. It's actually at the primary care level. So if you're not sure, ask your reg or consultant why do we need to make a consult, or why do we need to make this referral. A few more things bear in mind. Name the referral, don't demand for it. Remember, Department of Health and Medical Australia are actually currently investigating any hospital that require GP to write a name referral to any non-GP specialist at outpatient departments. So Web Referral, please organize it while the patient is still in the hospital and provide a detail if you want a GP to follow that up. It's almost impossible to arrange a social work referral in the community. It's very, very hard. Hospital online health team referral, once again, we can write a referral for the patient to go talk to a physio department in the hospital or podiatry department in the hospital. Once again, it's very hard. So it's better if you can organize it, or just tell the ward clerk to organize it for the patient before the patient discharged from the hospital. And prescriptions, that's a funny thing. When I was an intern, I've never been told how many items I can write on each handwritten script. So I used to write, 10 items on a script, and I've been told off by the pharmacist that you can't do that because I don't want to save paper. So only 3 items on each handwritten script. And if this is an authority prescription, please ask your consultant or your advanced trainee about it, particularly the consultant, because I can tell you that most of the basic trainee regs don't even know there's an authority script and what is the authority script for. For a patient who has a pension card, that makes a big difference because there's $5.50 for a medication. So for example, ciprofloxacin used for very severe infections. The consultant usually, if they say, patient is actually on Cipro and needs to go home with Cipro for another 14 days. When I was in respiratory team, the consultant is very nice. They say, "Oh, don't worry about it. I'll write an authority script, because otherwise you guys can't write it." So if you're not sure, you ask the hospital pharmacist to provide a 14-day supply, not just 3 days, or otherwise ask them to go to see the GP afterwards, because a lot of the time you provide a simple script that is actually meant to be an authority. Patient go to the hospital, go to the local pharmacy. They need to, and the pharmacist will say, "This is not an authority script. I can't give you that. Otherwise, you have to pay the full fee." Ended up, the GPs are fixing the error from the hospital. Work cover certificates you often encounter in your emergency term. Do not nominate yourself to be the treating doctors. Otherwise, you will just keep having this insurance company sending you the letter because you're not going to follow up with the patient. Okay, that's all. Any questions?
Any questions?
Yeah, any questions from anyone?
You can type it in the chat if you want, about how to write those good discharge summaries. And I think they count for a lot in the part of our intern jobs. I would say at least 20 to 30% of time, if not more, is ensuring a safe patient discharge. All right, well, feel free to type it in the box later if you think of any questions. So then I'll hand over to Prof Seng Chua, who is an ONG specialist, to tell us a little bit about consulting ONG. So I am going to share screen for a PowerPoint.
Excellent. Thank you, Lucy. Can you hear me?
Yes.
Okay, excellent. As Lucy has mentioned, I am actually I'm a consultant obstetrician and gynecologist working at Westmead. I'm also happens to be the chair of the board of AMSC. I'd like to welcome all of you on board. It's always exciting to be the first there, and probably so for some of you, the first time you can make a proper living. It's always very daunting in the hospital system, but nowadays, most hospitals, if not all, have a properly placed work safety, respect for every single person that's working there. So just find yourself at ease in your first few weeks. Now, just following on from Professor Lim's talk, I spent 2 years as a general practitioner. I have always interested to be a specialist. I have always I have interest always in obstetrics, but I thought I went to GP first, but I found it so stressful that I not do anymore. So back, it's just too stressful as a GP. All right, so yes, what Professor Lim was saying, it shows some respect to the poor guy out there who has to clean up all our mess. All we're doing in the hospital is acute cases. We try to be as comprehensive as possible, but the healthcare system is such that a lot of things are left in the community. Now, going back to ONG training, the first thing is I'm not going to talk about ONG training because ONG training is one of those specialty where it's only suited for a small minority of people. And most ONG units do not take interns because of that. And there's a lot to say about ONG training, which we don't have time for today, and it's not appropriate. However, you can send email or send to AMSC, and I can link you to the appropriate people in ONG. And right now, I'm actually writing another journal club article for our AMSC review. So by all means, join our AMSC journal club Facebook. It might be worth because it's about academic, it's about putting you back into basic medicine. You will find it in your first year as an intern or possibly JM or a very junior JM, or a lot of the time you just listen to what your registrar and consultant said. You can't even, you don't even have to use your basic training. It's all about clerking. But today, what's more relevant, I thought to talk to all of you, what is going to be happening this coming year for all of you whenever you that is majority of your work, which is medical clerking. So you are a person who actually follow a whole team and you're the bottom on the ladder the registrar, possibly your senior trained resident are all interested in a particular training. So all the other work are left to you. So you one of the things to show that how good you are is to have, while you're doing all this clerking, all this communication, to show some thinking in your clerking. So the most common thing our department, ONG department, get from you over this year is going to be getting a consult from you guys. Okay, so it's very important part of this, that is being able to communicate well, which shows that you are a thinking person, which shows that you are very well organized when you present. So how do you present in a consult? The most important thing is to make it really simple but succinct. So that you have to remember, whenever you do a consult, when you pick up that phone call, whether you're talking to a registrar, a fellow, or consultant, that person on the other side could be doing anything, because this is not part of, although it's part of his job, but it's unpredictable when he get a consult. So that's why it's very important to have that perspective on. That person could be in the middle of delivering a baby or operating, and he needs information that is just relevant and succinct and very simple. So I thought I just put up 3 slides, which basically have 5 points, and you're going to find that happening all over on your daily basis. Whenever you do a simple, whenever you ask for a simple consult, and I keep that together with the common term that people do for clinical handover, which is ISBAR. I'm sure a lot of you know what ISBAR is, because the New South Wales Health, or I'm sure it could be national, have identified that is an essential ingredient whenever you do a handover. So the first thing, like what Professor Lim was saying, when you pick up that phone, think about the whole situation first, and then your first sentence will be introducing yourself. Please feel really free to say that who you are, what's your name, and you're an intern, or you're a first-year resident, or you're a registrar, because the other side, on the other side of the phone, that person will know how much to ask, how much not to ask. It doesn't, as Professor Lim was saying, it doesn't mean that being an intern that the person would actually brush you aside. In fact, the person might actually talk to you more and try to be nicer to you and give you a lot more information. So that's the first thing, introduce yourself. So I have written in the red that your name, your position, and possibly from which specialty you're coming from, so that the person taking the consult know where they are going to go logistically. So the one on the ISBAR is the same way it is in the dark phone, introducing yourself and the others who are taking over. And speak slowly. A lot of times we find that when you are a bit nervous and you want to, and especially who are uncertain about a certain condition, why is your boss getting a consult for this? Just because somebody has got a PV bleeding, it could be a PR bleeding, or it could be a period, and the consultant is just going to say, we get this so common, the consultant is just going to say, oh, this person, is bleeding, get an ONG consult, and that's it. And the rest is up to you. So you're going to find yourself quite stressed. You're going to say, hang on, I've got this drug and alcohol person who has everything. The ONG person doesn't want to know. The ONG person only wants to know and want you to speak slowly who you are and and where do you work. And then the second part will be to talk about the situation. Why? What was the reason for consult? In general, there can only be 4 things. Number 1, you want a diagnosis. You want them to help you to get a diagnosis. Number 2, you want them to manage. For example, somebody has been bleeding heavily. It can be PR or it can be PV. and you just want, or you have found that it was a PV bleeding, like a per vaginal bleeding, and you said, well, you want to manage either over the phone or a definitive management. Or the third one, which is very common, and especially coming from the surgeon, they will say transfer of care, because anything that touch about gynecological area, the surgeon gets scared. They just say, look, that's transfer care. And you'll find that this is very common. People present with a lower abdominal pain, query appendix, and they will always say, hang on, it must be pelvic inflammatory disease. So they want transfer of care straight away. All right. So regardless of what the purpose is, spelled it out. All right. So that the person on the other side of the phone actually is home in, think about the situation. Or sometimes you just say, look, my boss just want you to know that we are going to operating on an appendix, but just in case it is PID, can you be on standby? Or my boss just wanted you to know that we did a CT scan on somebody who we're discharging, happens to find a mass somewhere, just to let you know. So that the other person, the ONG person on the other side, already know what was the purpose. Okay, so very simple, your name, who you are, and why are you making this consult. All right, so very, very simple. And then you start at your history. Your history should be very, very simple, again, on the background. All right, why is your patient there? That's in your ISBAR. Why is this person in the hospital? Right, for us, all we want to know is what's the patient's age, what's the parity, which means that how many children they have, because we always want to know that two basic. And of course, if it is an obstetric issue, which is unlikely, you have to say, well, how many weeks pregnant this lady is. And that is the only three things that you need to know. We want to know as a basic, all right? And of course, if it is a gynecological issue, sometimes you have to mention, especially if they are perimenopausal age, what their menopausal status. In other words, have this person stop having her menses, all right? Only after saying that three things, the age of the patient, the parity of the patient, whether it's gynae or obstetric, you still have to talk about parity because that has implication for us. And then the menopausal status or the gestational age. Then you present the problem requiring consult. For example, this person come in on an incidental finding of abdominal mass or having an abdominal pain or a PV bleeding. That's all. That's the most common thing that you could call. So just to summarize, you just say yourself, who you are, introducing yourself, and then what was the reason for the consult, and what is the background, which is the age, the parity, and the gestational age or menopausal status, and then why are you calling a consult? And that's it, all right? And the rest, the point for the next slide, point number 4 and number 5, these are something to fill in, all right? So if you present the first 3 points correctly, that registrar or fellow at the other end would already know what sort of diagnosis. In obstetrics and gynecology, is very strange and very simple that the first 3 sentences, basically we tell our registrar or a resident, the first 3 sentences that you tell me over the phone, if I haven't got a clear provisional diagnosis or a differential diagnosis, something is wrong with me or something is wrong with you. All right. So in other words, you don't present well, or I just don't have a clue or my knowledge is so bad that I have got no clues. All right. So it's very, very simple. It's only a pelvic organ. Okay. There's only about 6 compartments to look at. Then assessment. So basically, these are something that we like you to fill in. For example, it tells you, has there been investigation done? Now, most of the time we ask for ultrasound. CT scan is very irrelevant for us as a first line, although it could be an incidental finding that was already done. And blood test, don't start ordering it unless it is obvious. People order a lot of things, but you'll find that some of the more advanced trainee trying to show off their knowledge who tells you why are you doing CA 19.9, and they give you a whole lot of theory about this. Okay, you might not have the time, but take it easy because they are trying to sit an exam. they're trying to show, because that's what the boss would tell them, why are you doing this, and then they have to spill it out. Even if the boss doesn't know, the boss just pretend that they know, they just need a revision, that's all. And then the recommendation, right? For example, you might say, hang on, this patient happens to be ready to go home, and then the consultant just found out that she started bleeding today. All right, so you got to tell the registrar or the fellow to say, well, by the way, she's going home when, so that that person knows what to do. Okay, and then the rest are really leave it to the consult team to work out what they want to do. Sometimes it could be just a simple over the phone to say, well, this doesn't need an acute management. Just follow up in the gynae clinic. Make sure you tell them, you ask them how to follow that up, all right? Because they assume that you already know how to follow up the gynae clinic, and the next thing is you'll be ringing up switchboard, and switchboard say we don't have a gynae clinic for another 6 months, or COVID is here. So switchboard wouldn't have a clue. You just ask them, can I force book, or which clinic would you prefer, right? They will tell you. Make your life a lot simpler. Otherwise, you spend the next half an hour chasing this up, and your home team is going to say, well, what the hell are you doing? Okay, so, and don't forget, in your consult, in your discharge summary, if there's any consult, if there's any incidental thing that's happening, write it down so that the GP knows. Otherwise, the consult team only write in your record, in your home notes, what they suggest the home team to do. Your responsibility is still the home team. For example, if we ask for, if my team asks for an ultrasound, and the home team said, no, we don't need an ultrasound, it is up to the home team. So the responsibility still goes to the home team. So it's important that the home team, who usually listen to the advice of the consult team, otherwise they wouldn't have consulted, right? But just write it so that the GP can follow up. Very frequently you see that people actually lost that. They fall in that crack because they come in for one problem and then they happen to find another thing. All right. So very simple thing. As I said, the first 3 points are most important. When you do a consult, who you are, and speak slowly, and what was the reason for the consult, and what was the presenting issue. And that's very simple. Although it sounds really simple, you'll find that a lot of times you ramble on, and then people just give up. All right. All right. I think that's all the slide, isn't it? Yeah.
Any questions from anyone? You can type it in the chat. Otherwise, thank you, Prof Chua. I had actually 2 people ask questions for Prof Lim, if you're still there. And people tend to ask questions a bit later. So if you think of a question for ONG consults, feel free to type and we can ask the next break. But for Prof Lim, one of our interns asked, so you mentioned authority scripts. Is there an easy way of knowing which scripts are the authority ones, or do you have to type it into PBS website every time and check?
You need to type it into the PBS website. So actually the quickest way will be asking your ward pharmacist. Consultant often will remind you at discharge. A good consultant will remind you on discharge, but you need to, the best way will be PBS, because I don't believe the hospital prescribing system will tell you that. But the PBS website would actually tell you whether this is a streamlined authority or not streamlined. Streamlined authority means we don't have to call PBS in any GP's office medical software. As long as the GP is using a medical software, we can just put in the medication and print it out electronically. We will get an approval code from the PBS. Otherwise, the rest of the others, we need to either go through our PRODA, which is the system that you guys probably obtain your medical provider number, or the PRODA, which is the system that we can obtain the authority through that online portal there.
Yeah, I agree, because the hospital system computers definitely don't tell you. Some specialties like I've worked with who always require authority scripts, like the registrars or consultants will keep a script pad there in the office and they'll tell you which ones. Like dermatology always needs authority scripts for the weird creams. That's very special. But yeah, I sometimes also check on MIMS. I don't know if anyone else does that, because in MIMS at the bottom, it tells you how many tablets come in a pack and whether it's authority and streamline. So that could be another way to check.
I remember authority script, you need to ring the PBS for the approval number. Right? And that's another, as you pointed out, that sometimes the intern resident, they know to use an authority script pad, but there was no approval delegate number on that. So that means the script is still no use, because the PBS, you need to ring PBS to get an approval code there. But I think that's very hard for intern resident, because you don't know the indication to tell the operator. So the best way is actually, when you look at the PBS website, then they will tell you the authority is authority required for the following indication. Then you just read word by word as what the indication says. Then it's easier for the other end to approve the request.
Yeah, that's definitely great advice. And then someone else had a question about the dilemmas of writing up discharge summaries in terms of how much investigations to include. They were wondering, for example, would it be useful to have blood tests from both the admission and the point towards diagnosis and the discharge? Or do you only want to see the abnormal bloods? Or, do you want every single blood test they've had during the admission? Like, what degree do you think GPs would find helpful?
Yeah, usually for the blood test point of view is the last set of bloods before you discharge. Then that's the reference point. So if you give us the admitting blood, there's not much point, because back then, 10 days ago, if the patient come in with a STEMI, or 7 days ago, the troponin definitely is up. And I know how you come up with the conclusion. I don't need how high the troponin has gone up to. I mean, you can mention it in the discharge summary, but you're showing me the blood test doesn't mean anything. But patient might be having acute renal failure back then. What we need to know is whether the renal failure has been corrected or not. So if you're showing me that the patient actually have hyperkalemia, and the creatinine is very high, but at the day of discharge, I don't know where the base point has returned to, then there's no point for me to make any further reference in the future. So it's actually the last set of blood. And the rest of the most important blood tests, if, for example, the patient was admitted, at this stage with a trop level of XYZ, patient was admitted for following procedures, that's enough, because we all just need to know how this diagnosis comes through, that's all. But CT scan, MRI, usually you only done once in the hospital, so you just include those reports so that we don't need to repeat the scan again. Particularly for those with radiation, I'm very mindful about exposing patients with extra radiation unless it's absolutely needed. So if you have done a CT, chest, pelvic, abdomen, then just mention that and close the report. But then because we don't have to repeat it. Otherwise, the worst thing you want to expose the patient is having a CT scan now, and then a few weeks later, and then we expose them again with another CT scan.
Yeah, definitely.
Just one other thing, Lucy, one of the things just for the JMO, it might be worth asking your consultant, because some of you will be doing a surgical term, whether in your histopathology report that you should ask the pathology department to send a copy to the treating GP. Then sometimes it's safe for you, because some of the histopathology can be quite complex, although you can write a conclusion about what it is, but sometimes it's more complex than that. And a copy directly going to the GP, because some pathology department doesn't mind having a copy to somebody else, as long as it's authorized by your consultant. Just make sure that your boss agree on it. Some boss are having that doesn't like to do that, but I don't mind my resident, or if there's any intern to send that, because it gives the GP a lot more confidence having that histopathology, one whole page of detail, just in case something is missing, right?
Yeah, a very good point. In ONG, whether it's a DNC or any specimens pathology, like for gastro, we often get asked by patients, I recently had a scope done, but do you have my report? And all we have is an endoscopic report to say the specimen sample histopath, but what's the histopath? Then the patient doesn't know, and then we have to ring up the histopath department and ask for the reports. And often can take a few days for us to obtain the report.
Yeah, definitely some good points there. And also when sometimes at the end of discharge, we get asked to write a pathology request or an imaging request. I think, I'm not sure if Prof Lim would agree, you can always write CC the general practitioner that the patient sees, so that they're also kept in the loop as well when they...
And one more thing as well, when you're talking about, Lucy, when you mentioned about general practitioners, always confirm with the patient who is their GP. Hospital records doesn't necessarily mean it's correct.
Yeah, definitely.
Emergency departments admin officer usually do not ask patient who is their GP. And the patient might be admitted 10 years ago with one particular GP's letter, and that GP probably has already moved to different practices, or the patient never have seen that GP before, but the letters always get sent back to that particular doctors. And this happened to me, even though I've been looking after a certain patient for more than 10 years, the discharge summary always gets sent to a former GP because the medical admin just never bothered to change it. So always ask the patient, on our record, this is Dr. So and Dr. Smith or Dr. whoever is actually your GP. Is that the case? And if they say, no, I don't see him anymore, I move area, I see someone else, then tell the medical admin, tell the ward clerk to change it, please.
Yeah, definitely a good point. They are frequently inaccurate from previous experiences.
Yes, and I echo what Professor Chua said earlier on. Just be very frank about your position and what you're doing, and if the GP asks you certain questions, don't insist that this is what you have been told. Like I had a phone call from a resident, a senior resident, and from a rehab team, to say that the patient's about to discharge home. I'm just ringing you up to tell you that we need to perform a daily chest X-ray on this patient because he has pneumothorax. And I say, hang on, daily chest X-ray? Yes.
You want to discharge?
Well, if the patient needs daily chest X-ray, the patient should not be discharged. No, my boss said, no. The way she said is, my consultant says, okay. And I say, well, I don't think you understand what you're talking about. Go back and talk to your consultant, because I'm pretty sure your consultant will not have that ridiculous request to get an elderly patient to have daily chest X-ray in the community, okay? And then she went back and talked to the consultant. She rang back and said, yeah, my consultant said, no, that was wrong. Well, of course it's wrong. How can a patient be discharged with a daily chest X-ray?
Yeah, that's a lot. Definitely double check your plans with the consultant or reg, guys. Sometimes it's like they might say something and you misunderstand and you think that's what they said, but either they were having a lapse in it communicating to you, or you might have, understood incorrectly. So if something doesn't make sense to you, it's very worth checking with them. So, hey, just to double check, especially I think when you're a new intern, you can always play the intern card. Just be like, oh, just because I'm an intern, I just want to understand for my own learning, like, why is this that we want to do this? But in your mind, you could be thinking like, that's ridiculous. Surely that's not what we think. All right. Thanks for the discussion, guys. You can keep typing questions in the chat box if you like, but I'd like to hand over to our next speaker, Dr. Christina Lai, who is a renal physician, to share her thoughts of, what makes a good intern in the hospital from a consultant point of view.
Lucy. So hi everyone, I'm Christina and I'm a nephrologist, work at the private and the public hospital at Marta and Concord, and I also do some rural work at Wagga-based hospital and also the hospital non-specialist training program director. So just congratulations everyone, just feel very excited and happy for you all that you're coming on this journey. I know they're very anxious of being an intern, but I have to tell everyone that don't be anxious, because finishing med school already proven that you're a high achiever no matter what. So I guess everyone is kind of starting at the same point, no matter what grades you got at your medical school final exam. Doesn't really matter anymore. Sorry for those who studied really hard and got a medical like university medal or got all high distinction. Everyone just starts with a white paper now. So I get very excited for you all. And from now on, you basically decide what you want to write on your white piece of paper. So Lucy did ask me to talk about what makes a good intern, and I'm pretty sure you all have a lot of lectures now, even from your own hospital, about how to become and what do you need to do to become a good intern. But I just want to take a step backwards a little bit and talk about your why. So in particular, I want you guys to think about two different whys. One, the first why is why you want to become a doctor. I think internship is just a start of this medical journey. You will become a resident one day, a registrar, a consultant, and throughout these how many years, there will be a lot of difficulties, hurdles. You get quite distracted. So I think it's very important to always remember your very first why. I've seen a lot of people, even myself, get burnt out throughout at one stage of my career, and no one is there to really help you, because you are the only one who knows and understands why you're doing this. And if you don't hold on to that why, you get burnt out quite easily. So if there's one thing that I want you guys to take out of my talk or everyone's talk today, is to start thinking about your why again. Just write it down on a piece of paper, on your notebook, and anywhere visible. Every time you finish a 15 hours long shift, or even before you go to your night shift, when you are on your 14-day straight days of working, which will happen eventually, unfortunately, that you always go back to your why. I think that's quite important. And that gives you the main motivation on how to keep going on this journey, because there will be problems that you encounter, and there will be some emotional things that comes along. So there's a lot of price and sacrifice that we make along the way to build up a career. But if you hold on to your why, I'm sure the process will be a little bit nicer and easier. So don't be scared. The other why that I want to talk about is just think about, why do interns exist? And the reason I want to talk about this is because a lot of interns, even myself, when I started working, I get quite discouraged. I feel like I'm more like a glorified secretary with a doctor title on it. And that mentality or attitude is just wrong. You are not a secretary. Yes, you do a lot of paperwork, and you feel that you're not actually doing a lot about medical side of things, for example, giving out the treatment, but you're not a secretary. The interns, there was one consultant who actually told me the intern's job is basically to make your registrar looks good in front of a consultant. And the registrar job is to make the consultant look good in front of the patient. So after all, it's all teamwork. We all work together to make sure the patient is safe, the patient receives the good treatment, and the patient doesn't need to come back to the system if we can cure them. So once you think about why you are an intern, it makes it much easier for you to decide how to become a good intern. So basically, we all know that our job as a doctor, no matter who you are, no matter whether you're a GP, O&G consultant, whether you're a radiologist or so, these are the few steps that we do as a doctor. We're there to assess the patient's condition, screen for any complications. We are there to diagnose the condition. We're there to give the treatment for the condition that you've diagnosed, and then discharge them from the hospital setting, or even in a specialist clinic, you can discharge them from the clinic, or you continue to follow up according to their illness, whether it's a chronic illness or so. So these are the process that you go through. In the hospital as an intern, we do ward rounds, you do discharge summaries, you do consults. And these are the steps that you need to take and help all the other people to make this process efficient, timely, and quick. Everyone is busy in the hospital. It's not only the interns who are busy. Consultants are busy as well. Registrars are all busy. So to become a really good intern, you just make everyone's life easy. And we're all there to make everyone's life easy. So take, for example, doing a ward round. As a consultant, I can tell you that no one really enjoys a long ward round, okay? So even geriatrician, their ward rounds are long, but no one likes it. It's long because we need to be thorough. We need to make sure that the patient is safe. And we need to make sure that everyone understands the plan and everyone involved in the care of the patients knows what's happening, what are the next steps. So as an intern, what you can do to stand out is really to make sure the ward round is very short and effective. To do that, it's simple. You just need a lot of preparation. It might not be fair, but if you can come into hospital a bit earlier before your registrar or your consultant round, write down all the things that you need to know. For example, a patient who comes in with pyelonephritis, all I need to know as a consultant is whether the patient had the appropriate antibiotics, whether they have any more fevers, whether they have any pain, whether they're passing urine. So if you can get all these information before my ward round, I do the ward round and you tell me the patient is afebrile for 24 hours, the patient completed 3 days of IV antibiotics, and also the patient has no pain, all the blood tests are normal. I can very easily make a decision within 5 minutes of my time to discharge a patient and arrange follow-up, for example. However, if you come to the ward round and you click on the computer when I ask what is the temperature, and it takes forever for the computer to load, no one is going to be happy about you. And no one is going to be happy about the power chart system or online system that they use. So you won't stand out as an intern. Of course, you would say that, oh, this is not my job. But remember, you're not a glorified secretary. You are the doctor of the team as well. So even though you are an intern, you're basically helps going through all these process and helping the consultant, helping the registrar to make a decision of what kind of treatment to give and whether the patient is safe to be discharged. So if you don't flag it to the consultant might not even know as well. The other thing the intern is quite very useful in a way is, for example, you screen for anything that can prevent complications from happening. The simple thing is Dvt Prophylaxis. Everyone in the hospital who are in hospital for more than a day or two should be on some Dvt Prophylaxis. If they're not on it, there might be some medical contraindications for it. And as an intern, you can just raise it up and say, hey, this patient is not on it. Do you want to be on it? And it's simple things like this. You can actually prevent the patient from staying for a longer period of time. So if you know your job, you know your role as an intern, it makes life a little bit easier to be on a ward round, for example. The other thing is similar to doing a discharge summary. The whole purpose of a discharge summary is for continuation of care. So the GP is not in the hospital. For example, Professor Lim is not in a hospital to know what happened to the patient, but you need to make Professor Lim's life a bit easier to go through the whole process of assessment, diagnosis, treatment, and follow-up. So to make it easy, just include the things that can help Professor Lim to follow up the patient as an outpatient. If you think from that point of view, doing the discharge summary, it's not just a paperwork. You actually learn the process of why you need to do the paperwork. And imagine yourself as a GP as well. What do you actually want to know? And don't just simply put all the information in, because a lot of information, like Professor Lim would say, that it doesn't really matter. So really think through it. You can actually learn a lot of medical knowledge through doing the discharge summary. So don't think about it as just a paperwork. I learned how to manage pneumonia, community-acquired pneumonia, pyelonephritis as an intern. So when I become a registrar, I feel confident because I know what my consultant and registrar will do at that time. So try to use every opportunity to learn how to do it. Similarly, doing a consult. Why do you want to make a consult, and how can you make it easier for the other person to see the patient? Different disciplines will ask different questions, and the more you do the consults, the more easier you will pick up what is needed to be done. For example, simple things like a renal consult. There's always all these standard questions you need to ask. Come to me with a baseline creatinine level, the creatinine level right now, so I know how to compare the AKI. Urine tests, ultrasound are the basic requirements. So don't call the renal registrar if you don't have any of the information, because they're going to get you to go do all these investigation before you call them back again. So you basically waste everyone's time if you don't have enough information. So there will be times when you didn't know about things. For example, you don't know how to do a liver consult or like an ONG consult before you start. It's okay. Like the first few terms, you might feel a little bit lost as an intern, but the good thing is you can always go back to your consultant or even your registrar to ask, are these enough to make a consult? What other things you need to include? Don't be afraid to ask, like Lucy had said, just use the intern card. I've never done this before. Can you go through it with me? It's always nice after doing the first time of consult and people just tells you these are the extra things that you need to do. Write it down in a notebook or just remember it for yourself. But the next time you do it, you'll be much more efficient. So as an intern, just think about it. All you're trying to do is to gain all the skills to make these few process of assessing, diagnosing, treating, and follow-up patients, all these process to be easier. So once you gain all these skills, you will become a resident, a registrar, and continue to climb the ladder. So don't be afraid to ask, but always remember that your job is to make everyone's life easy. If you think about that, it'll be much easier to do everything. The other thing, as Professor Lim also talked about, just be nice to everyone, just respect everyone. No matter whether it's a patient, the patient family, nurses, security guards, even in the hospital, they are the ones who protect you from the aggressive patients. Even the cleaners, they're the one who protects you from getting COVID. So be nice to everyone. Yes, there'll be times that people get cranky because we're all busy, but everyone is busy no matter what. You might meet these people in the future. You'll be surprised. Even the registrar, for example, that I worked with when I was an intern, we become colleagues when we're consultants together. We give each other consults, and you'll be surprised who you meet in the future. So just be nice and respect everyone. Sometimes I still remember when I was an intern, I get quite frustrated when people keep pushing for discharges. But you need to think from their point of view as well. For example, the nursing unit manager, they have an obligation to discharge all the patient and receive new patients. These are the side that people don't tell you about. And these are the reason why they're pushing you to discharge a patient. So once you understand what other people's obligation is, you'll also understand how to make people's life easy. And when you make everyone's life easy, they will help you to make your life easy. And always ask questions if you don't understand. Always ask for help if you don't understand. As interns, we don't we consultants or registrar don't expect you to do, say, for example, treat a patient with STEMI, but we do expect you to at least recognize the patient is sick in the hospital. For example, if the patient has a blood pressure of like 60/40, for example, or a heart rate of 130, I don't expect you to initiate treatment, but I expect you to at least push the medical button or call for help. Some of these nurses are there to help you on the floor, so be nice to everyone. You will be worried about career progression. I have to say, this is a thing that everyone worried about as an intern. Even now as a consultant, I think about career progression as well. So it doesn't stop, but I just want you to be very open about it. Internship is a time that you go through different disciplines and to experience different disciplines. In med school, we learn about a lot on the theory side of things. When it becomes working, it's very, very different. The experience is very different as well. I still remember when I was an intern, I really want to do psychiatry. I tell everyone that I will do psychiatry no matter what. I shut down. People keep telling me I need to become a medical person. I was like, no, I want to be psychiatry. I just want to talk to patients who have depression and so on. Until I remember a day working at Liverpool Hospital at the emergency department, there was a psychotic patient that climbed out of his isolation room through the roof and out on the other side. So we need to get like fire brigade people to come to the hospital. It was just like horrendous. And at that point, I know I can't become a psychiatrist anymore. Like I was too scared, seriously. So just be open. You will never know. Like every time you do a different discipline, really dig into it and see whether you like it or not. I know a lot of people who would love to become like a surgeon, and after they did all day in surgery, they didn't like it. They like looking at blood tests instead. So don't be surprised. Also try to find a mentor early in your career as well. I would highly recommend that, because the mentor has gone through your stage. They kind of give you advice so you don't have to go through all the painful part that we have gone through already. They can tell you what to avoid. They're probably easier and understanding that they know what's best for you sometimes. But after all, don't follow other people, what other people do. For example, a lot of people will say that, oh, you need research on your CV to get a job. That is not true. Like, you can become a consultant with no research at all. You can become a professor who has no research paper. You can become a professor if you teach a lot as well in the university. I still remember there is a respiratory physician, Professor Tara McKenzie, working at Wagga Hospital. She's one of the highly regarded professors. She tells me that she has never published a paper in her life, and she doesn't regret about it, because her calling was actually to teach, to mentor medical students. And because of so much work that she'd done, she's now the professor and also the dean of the Rural Medical School. And so research is not the only way out. A lot of people can do teachings. A lot of people go into management. You will always need different kind of people and different skill sets. So just be really open about it. And there's a consultant who kept telling me about my career progression. There is no wrong decision in life. Just a true story about myself. I also ran into the trap of doing research after my advanced training. So for the last 4 years, I'm trying to do my PhD as well, without thinking whether a research project is actually my alley of things. Like, I hated my research, I can tell you that. I did a basic research on transplanted mice. I have to like treat mice, do a mice ward round instead of human ward round. Not knowing that, I really hated it. Like, I'm not a basic science person. Before my PhD, I've never been to a lab. And I always feel that the first few years, I always regretted my decision. I was like, oh, this is the horrible life decision that I've made, the worst decision. But then my mentor came to me and just reassured me there's no wrong decision at all, because throughout the last 3 and 4 years, I have gained so much skills in other parts of my research. I learned how to do a biopsy. I learned how to do histology slides. I learned how to write up an article. I learned how to do research. So there's always things that you learn. There's no wrong decision that you make for your career in medical world. There is also life outside of medicine. Just remember that work is only a very small part of your life. You still have your hobby. You still have your family. You still can build up wealth, buy your first home. Don't forget about life outside of medicine. Even if you're not happy at work, it's just a very, very short part of your life. Always remember what else you have. This is the very beginning of your medical journey. And don't forget, there's always people who has gone through internship like you right now. A few years ago, I was like you. You'd be surprised. Next year, you'll be here giving talks to fresh new interns and giving them tips. So don't be surprised. Okay? Always ask for help if you run into trouble. If you feel that you're burnt out, ask for help. We've all been there before. Any questions for me otherwise?
Any questions, guys? You can type it in the chat or message me and I can ask the questions. Otherwise, thank you, Dr. Lai, for that very insightful talk. I definitely think that a lot of us forget some of the, especially when you start at the beginning, when you talked about the why. I think a lot of us find that it is like a bit of a, you know, you churn through your day at the hospital and you just forget why you're doing things, but you just know that you have to get things done. But bringing that perspective and being mindful of that, I think would really get you through some tough times. And also definitely debrief with your friends and your registrars, even if it's just to complain about something. I think that's even fine. Like, it doesn't have to be productive debriefing. You can even just complain about what a shitty day you had. And everyone has those days. And it's very helpful to talk to people, because then you realize everyone else has also had one of those days, and you don't feel so like, is it just me that's having a hard time as an intern? I feel like everyone that you talk to will say, I had hard times as an intern. Like, no one said, oh yeah, internship is easy peasy, don't worry, you'll be fine. Like, everyone acknowledges it's hard. So keep that in mind. And your goal, I had someone say, like, your goal of internship isn't to like thrive and be a great doctor, everything. It's just to survive internship, to learn the skills. And as long as you come out at the end, you'll be okay. Last call.
Can I add in something so that one of the things like what Christina was saying is to get yourself outside, like joining. I'm not trying to be self-promoting, just trying to get yourself outside to say, for example, join some medical and health link organization outside so that you broaden your whole spectrum. It's really helpful for you. Like, for example, I just sent off a second journal club article for our Facebook, not because of anything, because that's part of my learning in obstetrics and gynecology. Like, I just sent it off about a journal article that's been published just 6 months ago about caffeine consumption in pregnant women, whether it's linked to stillbirth. And that sort of thing is quite fun. I like it, not because of, I like my job, but there's only a certain limit of what you can do in your job. And I'm not the one, I wouldn't say I'm the one who would be living having no life. I play badminton 2 or 3 times a week. But part of, you want to be outside there, you want to share your fun with all the people. I just sent it off, a journal article with a few comments, and it's good fun. And then if you guys like to have that sort of thing, to link it together, you broaden your whole opportunity. I think it's worth it. Enjoy yourself rather than focus on, a lot of times your career opportunity doesn't come from just working on the job. Your career opportunity come from maybe the boss or somebody outside more senior than you discover your talents somewhere that they picked you up from that area. And I frequently pick people up from out of the blue, where people don't actually, where my colleague actually doesn't know where this person come from, because I joined all these things so that I know. All right, so just enjoy yourself. Don't look at your job. Say if you have a hard day or a consultant screaming at you one day, your career is not gone. All right, we get all the time. Even as a consultant, our colleagues scream at us all the time. It's not a problem. All right, that's part of medicine, which is hard, which is not fair, but that's what it is at the moment. Okay, you can, your job start with losing out. You just have to repair what the patient come in for. You are not an engineer, you're not there to build a bridge. Somebody come in, they're sick. You're not building somebody's gene to make that gene more better, unfortunately. You've got to recognize that. There's a limit in what you can do. All right.
Thanks, Prof. Definitely very true to like go out there, you know, speak to people who are more senior than you, even just for some advice, just in general life advice. People, I think in general, like giving out advice when you're genuine about asking for it. So, and you never know what kind of great advice or great people you might meet that way. And yeah, and go for coffee with your regists and consultants. I think it's important. You need to get your jobs done and get your discharges done. But, you know, when you can be organized and they say coffee, you always say yes. Even if you don't drink coffee, you don't have to drink coffee. You just go with them for the socializing. I think that's the only good part about ward rounds, is that after ward rounds, you can go for coffee. All right, so there was going to be one registrar recorded talk, but in the interest of time, and because we've had such good discussions, I think we'll end it here and we'll upload the talk as a recording, and we'll send you guys a link to watch it. And this one will also be recorded if any of your friends missed the session but would like to watch it later. So if there are no more questions, I am going to say that we end the talk here, and thank you so much for all of our speakers, Prof Lim, Prof Tra, Dr Lai. Your wisdom is very much appreciated, and to all the commencing interns, good luck. Take each day as it comes. There'll be good days and bad days, but I believe that every one of you will make it to the end of this year and look back and say, wow, I've grown a lot, and have fun. All right, thanks everyone. I am going to end the meeting. Have a good rest of the weekend. Bye.
Thanks everyone, good luck.